Ariel. Hello,
Yes,
Ariel.
doctor. Yes,
You
doctor.
have to admit those people that are in the waiting room.
Okay. I can't see the waiting room. I'm
Oh, you
just
can't
seeing
see
the
it?
panelists and the attendees.
Oh, really? Yeah, that's what I need to do. You can't, there's no option that says allow or talk. And is there an option that says promote to panelist?
Yeah. Yeah, I'm trying to promote panelists,
Yeah,
but
yeah, that's the one that we need. That's the one.
okay.
great. Saeed's here.
Merry Christmas.
Hey, hello, Zanab. How you doing?
Fine, thank you, sir. How are you?
You're welcome.
Thank you, sir.
Oh my God, Kiki Terrell's here. And Saeed. Hey, good morning. Hey, are you Saeed? How you doing?
Good morning, Dr. Said. Good morning, Dr. Sinab. Good
Well,
morning,
that's
Dr. Kiki.
exactly who we want to come. I mean, people like Saeed.
Yes.
Trying to get Kiki Terrell. He's a big neurosurgeon. He gives conferences. Hello, Kiki. Are you there? Some people just prefer to watch. Oh.
Hi, John.
Bonjour, Dr. Said.
Hey, Saeed. Good morning, Saeed.
Yes, good morning. How are you?
Good. How you been today?
Fine, and you?
Well, I'm glad you came because this is a topic that concerns you, right?
Yes, yes, it's interesting, very interesting.
Good.
Ariel, how are you?
Bonjour, Dr. Said. Je vais
Bonjour,
bien.
comment tu vas?
Comment allez-vous? Je vais bien.
Ça va, ça va, ça va. Beaucoup de travail parce qu'on est en effectif réduit, mais ça va, très bien. Il fait très chaud ici, on est à l'été.
Hey, Manuel.
L'île de la
Bonjour,
Réunion.
ça va?
Docteur Manuel.
Bonjour, Manuel, comment tu vas?
Ah, ça va bien. À vous?
Très bien, très bien. Alors, quel temps il fait en Russie?
Le temps?
Le temps, oui. Il fait
Ouais,
froid?
trop froid.
Ah
Trop
oui,
froid.
d'accord. Trop froid.
Vous savez qu'à la Rousse, trop froid, tout le temps.
Oh, Manuel, you speak French too? Jesus Christ. Can you?
Yes, yes.
Your screen, Manuel, your screen is sideways.
I don't know how to, oh, wait, let me see how I fix this.
Turn the camera sideways. What are you? You're not using an iPhone, right?
No.
Yes.
Okay. Do you see me?
No,
No, not yet, doctor.
no. Yeah. Oh, how shots here. Good. We can see Saeed well.
Yes.
Yes.
Oh, let's see here. Oh, he must have dropped off.
Good morning, Dr. Harshad.
Good morning. How are you?
Good morning, everyone.
morning,
Hey,
doctor.
Harshad, how you
Morning,
doing?
how are you?
Hi, John. How are you?
Good, Harshad. I got a banner I want to show you and to give your opinion.
Yes, sure.
Okay.
Okay, okay.
Yeah,
Yes, let me see.
yeah, Manuel, it's good. It's good. A
Yeah,
little lower down a little bit. We're cutting your head off there. There you go.
Okay.
That's
Being
probably the
Dr.
most
It's
popular
good.
background. San Francisco. Have you been there, Manuel?
No, I didn't have the opportunity yet.
Oh
I hope
man,
to have the opportunity.
you will someday. It's a great. I think it's the best city in the country.
No, the big
Yeah,
word.
the best.
But here I just see white, snowing, snowing.
Oh yeah, everywhere you go, there's a beautiful view because it's built
Yeah,
on a hill. A hill.
well,
Hill.
you know, snow is only pretty to see in postals, in the movies, but when you are here, John, is
You got it already, right?
sorry?
You got snow already, right?
Oh, of course, of course, of course, a lot of snow, a lot, and it's
Really?
right now it's not so cold. It's -8.
Oh,
Whoa.
Here
that-
it's not so cold.
oh,
Here it's
okay.
not so cold because last week was in -20.
Oh,
Okay, 2 minutes, Manuel. Yeah, I figured I'd call you, Manuel, because it's slow now with conferences. There's not many.
Sorry?
There's not many conferences now. Everyone's, taking time off and stuff.
Yes. A lot of people is, Christmas here because in Russia they use the Julius calendar. They have two calendars.
Right.
So
mm,
Christmas is gonna be after 12 days.
Oh, really? A lot of big Jewish population in Moscow.
The population?
There's a big Jewish population in Moscow.
I don't know.
Oh, okay.
I don't know. But the majority of the people, they are Orthodox.
mm.
Okay, good. You ready to go, Manuel?
Yes, I am.
Okay, 10, 9, 8, 7. Hold on, let me get my pen. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett of Neurosurgical TV. We have a nice webinar. We threw it together at the last minute with very active Dominican Republic neurosurgical resident currently in Moscow. He's going to talk about exoscopes and using it in the third world. Okay, welcome, Manuel. It's all yours.
Yes, thank you so much, John. Thanks to everybody for assistance today. Today we're going to talk about a low-cost exoscope as an alternative method for the low-income countries. I'm going to share my screen with you now.
Not yet.
Yes. Okay, are you seeing my screen now?
Yeah.
Yes.
Yes,
Yes.
doctor.
Perfect. Okay.
Yes. Once again, thanks to everybody for assist today. So first to start, I need to explain very well. I don't have any kind of conflict of interest in presenting this. This is not a company. I am not receiving anything for any company. When I'm talking about some products I try to don't put any kind of brand, okay? So also, this is not a microscope killer, okay? This is an alternative method. This is not like to use beside the microscope, because for that, there is some better, much better exoscope, but also much more expensive, okay? So after I left this clear, we're going to start. It's important to know that more than 5 billions, yes, I say billions, okay? So more than 5 billion individuals have a lack of access to essential surgical care, not only neurosurgical care, all surgical care. Neurosurgical care is especially limited in low-income countries. So describing neurosurgical care in low-income countries are critical for understanding the global disparities in access to neurosurgical procedures. So to better understand these disparities, we're gonna show some studies about the low-income countries' neurosurgical parities. Our background is first we need to understand the operative microscope and the exoscope have a significantly advanced in the modern neurosurgery. The operative microscope have a very big significance advance in the modern neurosurgical care, spine surgery, vascular surgery, even trauma surgery. So in all the field in neurosurgery, the microscope play a big role, okay? But continues to be limited by the high cost. Remember, we have a lot of country here, okay? A lot of city here, and even a lot of city here and country here, okay? And some countries here. From Latin America, where I come from, a lot of country don't have the access to the microscope, okay? Please, I don't want to, because maybe I put some, of course, I put some place in Brazil or Argentina or in Chile, they have the possibility. But remember, there is some rural cities where they don't have the possibility of the microscope. I don't want to use the term of first war, third war, because it's, you know, it's a Cold War terminology, and we don't try to use it, but it's in reality. So we believe the novel low-cost, high-definition exoscope may improve the surgical corridor through the advance of illumination, ergonomic, the magnification, and a deep of field sensation. So we believe it can be useful in some kind of these countries where maybe not the full country or some cities don't have the possibility to use the exoscope, to use the microscope because the high price it has. But not only for neurosurgery. So the current question is, there is a need to use a low-cost exoscope if I can get a second-hand microscope in the market approximately at $15,000. That was a question somebody made me in a group, like, we can have a second-hand microscope at this price. The answer is, only countries have this $15,000 in the neurosurgery department. All of they have? That's the question. They have all of them? Because there is some countries, as Sierra Leone, they don't have even neurosurgery in that country. Not even one single neurosurgery in that country. So how we can believe they have a $15,000 to get a second-hand microscope? And remember, it's not only get the products, also there is a lot of bureaucracy we need to solve. Get the microscope, the delivery, so it's not so easy. So here I show some specification about this low-cost exoscope. As you can see here, this is the exoscope. with the camera, and this is the light. This is the light here. This you see here is a microphone arm. Okay. As you can see, it have a 48 megapixel sensor. This is the frame of the RAID work. You can record video at 4K, so it's enough for some surgery. You can see the magnification is 4 times digital zoom. It have a white balance also. You can see here the camera, and you can see the picture of the quality of the picture and the quality of the videos. The mirror is a standard mirror. You can see the frequency here is 50 to 60 hertz, okay? And it can be adapted to any kind of modern monitors. This is the power supply is used. And you can see here the work distance. You can even work on 50 centimeters, okay? You can even work on 100 centimeters, okay? I'm gonna show you later. In this time, you can see here, we put the back on, we put an endoscope back to cover the exoscope. But you can see the arm, and on the full exoscope, you use the sterilization in it. The only part we didn't use the sterilization was in the camera. As you can see, look the weight of the exoscope, and you can see the size. So it means it can be transported by anybody. So another question is, it's hard the installation of the exoscope, because maybe some people think it's gonna be hard and the microscope is already there, but no. First, you see here in this picture, we put the exoscope next to the table, to the operation table. We fit it in the operation table. So you can see here, this grab is going in the lateral part of the operation table. But also, if you want more height, we use the serum stand, as you can see here, and that's gonna give you more mobility and gonna give you more height. We cover it with the sterile part here, as you can see, with some sterile tower, and the rest of the exoscope here is sterilized, okay? So the time of the installation after you practice, of course, 2 or 3 times, or you can just see it, and you can gonna see it's very easy. It can take only 5 minutes, because the camera, the exoscope, and the light, they are all together with in the sterilization machine, and also the arm, the cables also. So to try the exoscope, what we did a comparative study between the use of the low-cost exoscope and the surgical microscope in the spine surgery department in the clinical hospital of the Russian Academy of Science in Moscow. We use patients with degenerative spine disease with some spondylolisthesis. And between November and December of the current year, we use the low-cost exoscope in 8 patients. And also we use the microscope in 8 patients, okay? Both of them went in undergoing a fusion interbody lumbar transforaminal, okay? In TLIF. I'm gonna show you the picture. All these pictures, they are taken with the low-cost exoscope, as you can see here. You probably can work, and you can see here the nerve root, the L5 nerve root. And here we're making a TLIF with the wheelchair approach, where we're using the tubular retractor here, for example, and we are making the bone removing. In this one, we are doing the annulotomy. You can see the scalpel here, and also this is the tubular. You can see here, this is the tubular retractor, and here we're using the interdisc expander. Again, in this case, we use in the normal T-lift surgery. So you can see here the dural sac. You can see the good illumination. Also, something important is you can use with the Exoscope is if we use we can even leave the Exoscope during the whole surgery, and you can have somebody as assistant to manipulate, and that you can use as a teaching instrument, because as you can see here, the two surgeons, they are performing the surgery, and the head of the department here, this is Dr. Renat, he is coordinating the surgery. He's just saying to the doctor how to perform the normal T-lift without the use of the microscope. It means, because we need to remember, the microscope bag is have a cost. So if we can use this kind of instrument, we can even reduce this kind of cost in some kind of surgery. But of course, nothing is perfect. So the low-cost exoscope has some limitation. The visualization property of the low-cost exoscope with the regard of the deep perception, the pictures quality and the illumination were rated in median if we compare it with the operative microscope by the surgical team. Also, the lighting. That was a big problem in the beginning because we use the low-cost exoscope at least at 20 to 40 centimeter high. So the light was a biggest complaint by the team to minor inferiority if when they compare it with the operative microscope. Another of the limitation of the low-cost exoscope refer to the easy reposition, because the team needs to get used to use the exoscope. Also remember, we adapt a microphone arm to the exoscope. It's not like we're using a Will's arm. It's not like we're using a Martin's arm, for example, or a Mitaka arm, for example. So we're just adapting it. Also, the management of the reposition of the low-cost exoscope, they say it's a medium to low. They compare it to the operative microscope because it's more easy with the microscope. So we make a survey, a questionnaire to the whole team, and the nurse we make to the whole team of the department, to the chef of the department, the consulting neurosurgeon, the resident, and the scrub nurse. Those are the questions we made about the brightness. That was a very important one because we need a very good source of light. Also, what the operator, the second assistant feel using the low-cost exoscope, because in that way, even the second or the third assistant have more visibility using the low-cost exoscope. So if the person who used it was the operator or the assistant, also we ask about the imaging quality in the low-cost exoscope, if it's better or not. So was convenient to perform the surgery as an assistant or a scrub nurse with the low-cost exoscope if we compare it with the conventional binocular microscope. Also, if it's easier to teach, and we put emphasis on this one because we use the exoscope very frequently. We use it as a teaching instrument because we put the exoscope without sterilization outside of the operation field with the big eye. It means it's not gonna bother. It's not gonna be in conflict with the operators or the second one who's performing the surgery. So at the same time, everybody is seeing the surgery from the beginning to the end. The easy zoom, if they perform the zoom with the exoscope, it's easier or it's not comparing with the microscope, and also the focus. the reposition, and the preparative setup of the microscope, of the exoscope. As you can see, as we said before, it's just 5 minutes. 5 minutes, maximum 7 minutes is the time to installate the exoscope. So also we ask if the operator gonna recommend to the college the low-cost exoscope, if they gonna continue using the exoscope. Everybody say rather yes to absolutely, because it can be a very good alternative method. And if they think the low-cost exoscope has a potential to improve the neurosurgical care in the low-income countries, because again, I need to make emphasis. This is not for, this kind of exoscope is not for the United States. It's not for Europe, okay? It's not for some country you understand me. It's not for high-income countries. It's for low-income countries. So we cannot compare it with a Beaton 3D exoscope, or we cannot compare it with a Pentero 900, okay? And we ask, in which kind of surgery you think the low-cost exoscope can improve? Our conclusion was the low-cost exoscope can be a very good opportunity as a teaching tool, or even as an alternative method to perform surgery. The large monitor also resulting in immersive surgical experience, because as you see in the picture, we use a very small TV and give a multiple team member the same high quality view as the primary operator. The exoscope possesses a more ergonomically favorably setup as we compare it with the traditional microscope, because you don't use to use this expensive bag, allowing the surgeon to be in neutral position despite the operative angle, and it can be used in developing countries. Here I left some of the some papers talking. They explain about the neurosurgery in some low-income countries. As you can see here, I didn't find this picture in bigger one, but you can see a neurosurgeon was performing a surgery, and you see an assistant using a focus to give a light. Okay, so you need to remember this is the reality in some places, okay? So the decision time, our result was the decision time and the visualization of critical structure was comparable with the low-cost exoscope and the standard operating microscope. The low-cost exoscope allow for larger operative corridors, enhanced instrument maneuverability, and also a less obstructing in passing instrumentation. Because remember, in the microscope, you have at least 20 centimeters, 30, more or less, to pass the instruments. But with the low-cost exoscope, when we put in the serum stand, we have more than 50 centimeters to operation field free, okay? So thank you so much. I left this phrase because I like it very much. It means un día, cuando ya no estés, serás lo que hiciste. It means one day, when you are not here, you will be what you have done. So thank you so much.
Thank you, Manuel. Thank you. As always, you are active in the research for solution for the countries, low-cost countries, a lot low-income countries. It's a great congratulations for your work and for you do. It's very interesting. So yes, there is the good topic, and I work with endoscope of otolaryngologist from several years ago, and I start with spine surgery, discarnation, and laminotomy, minimally invasive. But the exoscope is a good idea. It's in cost is not expensive. So I think if we it's a good idea, and for the people who haven't the possibility to have a microscope, a good microscope, or endoscope for assistant surgery.
The price of the, thank you so much for your words. The price for the low-cost exoscope was $200. For example, my college, Dr. Peralta, he have a big serial of cases, and he's gonna present it in brain surgeries. I just presented the serial we have here about spinal surgery.
Thank you, thank you.
To you.
Okay, thank you very much, Manuel. We have a question from Raghavendra. I believe he's a neurosurgeon in India. He says, where and how do you buy the parts, get the parts for the exoscope?
Yes, I get it all in AliExpress. In AliExpress, I can share the link with all of you. As you can see, the price is less than $200. Okay, you can get it for less than $200 with the delivery included.
Yeah, when you get a chance, just type that in the chat, okay, Manuel?
Yes, of course.
I'd like to welcome Ismail Peralta. Apparently, he uses this. Good day, Ismail. Can you hear me?
Hi, everyone. Hi. Can you hear me, John?
Yeah, yes, we can.
Okay. I'm going to share my view. Congratulations to my partner, Dr. Manuel Encarnacion. We're going to do a pragmatical presentation, just showing some of my surgeries. Here we're gonna see some videos. I want you to join me. So first, I have done roughly 40 cases using the Exoscope, but I'm just presenting the first 16 cases. It's a multicentric study. I have moved the Exoscope through 3 kind of hospitals, both private and public hospitals. The sterilization methods were oxide ethylene and formol and hydroxy peroxide. Here we can see some of the views. We have the let me okay. Here you have the TV screen. You can use whatever screen you want. That's a 55 inches screen. Here you have the parts of the exoscope. You have the microscopic tube. You have the camera. You have the light ring. You have the support arm. You have the HDMI cable, and that's it. So hold a second.
So you're working with Manuel, Ismail? You're working with him?
No, I'm from Dominican Republic. I'm now at my country. It's a country in the Caribbean Sea.
Oh, okay.
Yes, maybe you know it as Punta Cana, but it's not Punta Cana.
Oh yeah, Punta Cana. Yeah,
it's just a small town of my country. John, I can move my my screen now. I cannot pass the slides. Okay, now I can.
Yeah, it's tough. There you go.
Now I can. Okay. So this is 4 kind of setups. First, when we use the the cranial setup right up to your left. Now the cervical one, sorry, you have the C-arm there, you have the TV screen there. When you need to operate in cranial surgeries like aneurysm or tumors, here the lumbar spine and dorsal spine and the lumbar spine. So we had 8 cases of spine surgeries, 7 cases of cranial, and 1 case of peripheral nerve. From 2010 to 2018, there were only 25 studies talking about the exoscope, and we are number 11 in cases. We have 18, most of them were under 16 cases. You can see some of the pictures, maybe Manuel show you. Those were my pictures. You have there you have a parasitic surgeries, nodocystic sarcosis in the posterior fossa. You have the aneurysm surgery, cellular surgery, pituitary surgery. You have tumor surgeries. You have peripheral nerve surgery, spinal tumor surgery. You can do a lot of things using the exoscope, but I prefer doing spinal surgeries because you don't need to move a lot the exoscope. It's not an advantage of this device, you know. So let's start. I'm going to show you a left ACM MCA aneurysm. You can see here. You can see here the aneurysm in the M1, M2 region. And then you have the video. So here we are draining CSF through a subfrontal approach. You can see the focus. It's a manual focus. You can see there the factory nerve and the optic nerve down there. You can see both optic nerve. There you have the aneurysm. We're using the ultrasound probe always to see. We dissect the neck. I'm using the exoscope 100% of the time in this surgery. I have practiced a lot to get an hysteresis because the lack of hysteresis of depth perception is a draw in this kind of surgery. But if you practice a lot and you have confidence and you have good hands, because it doesn't work in all hands, you know, but on my hands, it works perfectly. So I changed the aneurysm clip several times. I punched the aneurysm neck when I was not sure about it, and I repositioned the clip using always the exoscope, not once looking at the surgical field using my eyes. Here you can see it's not close enough. So I reposition my clip. And that's it. So it's not always perfect. The patient made a bleeding. It has some microaneurysm on Charcot-Bouchard, and he made a hypertension 1 day after surgery. But we didn't operate him because he was alert, although he had a aphasia and a contralateral hemiparesis. But 1 month after surgery, he was doing very well. Here you can see 1 month after surgery. You can see here the clip, and you don't have the aneurysm in this way. Look at the aneurysm preoperatively. You can see here the clip. It's already secured the neck of the aneurysm. The patient is doing very well now. He only has a mild motor aphasia. So the setup time for me, for my team, is 15 minutes. When I operate with resident, myself prepare, set up the things there. So this one is a left side acoustic neuroma. You can see here it has a two component. It has the cystic one pushing the brainstem and the fourth ventricle, and you have solid part. If you see this tumor, maybe you would like to remove all of the tumor, I think, right? The solid and the cystic part, but literature said that this has a bad outcomes if you try to remove it from a whole. You can have patient with seven nerve paralysis and stuff. So I'm a gamma knife surgeon. I work for a gamma knife device here in my country. Is the only one gamma knife device in the Caribbean. So I went first to drain the cyst, because if you see the solid part after draining the cyst, you maybe wouldn't offer the patient surgery. So let's see, how was it? Okay, here you can see it before opening the dura. I can teach the residents. The residents perform this part of the surgery. I can talk to them without being there. You know, they want to operate. I know that. They're opening the dura. In this part, they were using both the eyes and the exoscope. They had loops. Now it's my part. I'm draining the CSF. I can see the lesion down there. I had to move the exoscope maybe 5 times. That never happened in a spine surgery because you have only one side of vision above the patient. So I was removing the tumor, dissecting the tumor from the vessels and the nerve, and it was very thicky, hard, and then I managed to drain all the cysts. Maybe if you see the post-op imaging, now you can see there the patient is doing very well without any sign or symptom. And then I offered her gamma knife surgery. It was 8 months ago. But this is the MRI scan after surgery and before the gamma knife. So she's doing really fine, and the exoscope works perfectly for her. So we have the working distance in my case maybe was between 20 to 19 centimeters. That's my one of my colleagues helping me there. So the zoom and focus, you need to move a ring focus device around the microscope tube here, but that's about the focus. About the zoom, you need to move the exoscope down to the patient or get it out of the patient. So it's a manual zoom and focus. It's some of tricky sometimes, but when you find the perfect spot, you can leave the exoscope there and start operating. You have the screen there. So let me show you some cranial surgeries again. This is a parasagittal meningioma in a 54-year-old patient with convulsions and severe headache. You can see the edema surrounding the tumor. This tumor doesn't need gamma knife for now because I have found in some of my studies that when you perform gamma knife, when you have this kind of edema on a tumor, you can worsen the symptoms of the patients. So first of all, I offer him surgery to remove a big part or all the part of the tumor, and now you're going to see what I did. Hold on a sec. Okay. You have
Ismail, we don't hear you.
Yeah, thank you, Saeed, for noting that.
Okay, okay. Thank you
Okay.
very much. So this is the tumor. This is a vein over the tumor. This is the superior sagittal sinus. This is a small intra-tumor debulking first. And shrinking the capsule there. And now I'm removing the attachment to the falx. I'm burning the attachments. I performed a Simpson 2 resection. I didn't want to mess up with the contralateral side or remove the falx at that level. It was the posterior part of the superior sagittal sinus. It had a part protruding the superior sagittal sinus. I didn't touch it. I offered him gamma knife 6 months after, and he's doing very well now. So this is the empty surgical region. That's the surgery flow, and we have finished. So you can see here the pre-op and the post-op. Now you don't have edema surrounding the tumor. You can see here, and it has a little part over here over the superior sagittal sinus inside the sinus. So I offer him gamma knife, and he's doing very well. This is not about being a Superman or you try to remove all the tumor. You can take it out off of it, but the patient maybe will done very bad on the ICU or at his home. I prefer doing a well done resection, and if you have some tumor there, you can offer him a gamma knife. So here we have another case of neurocystic cirrhosis. He had a hydrocephalus. I performed a peritoneal shunt first. The patient were doing very well, but he had a cystic lesion on the posterior fossa. It was compressing the brainstem. You can see all of it going through the fourth ventricle to the cervical spine, compressing the brainstem dorsally. So, hold on a sec. So this was after surgery. The pre-op image, and you have no cyst on this way. He's doing very well. I think I have a video here. Let me see. Okay. I'm opening the dura, opening the dura mater. So you can see the thickness of the arachnoid layer right there. Open it. I'm always careful there. That's the light of my loops. Remember, I always use loops because sometimes I need to use it because the ergonomics, the position, you can see the cyst over the amygdala of the cerebellum there. Now I'm using the exoscope. Down there you can see the pica, one of them. It was through a small opening of the dura, all the surgery. You can see the pica there. There's a cyst. Now I've cleaned all the cysts compressing the brainstem. And that's it. So let's continue. Here you have some pictures doing an aneurysm case, doing a spine surgery case. Oh, let's go to the spine cases. You have a C1, C2 left schwannoma. You can see the big tumor compressing there. The spinal cord, it moved through the left muscles to compressing the vertebral artery of the same side. And this was the surgery. Here, you can see the pre-op image and the post-op. Here, the pre-op and the post-op. It was a complete resection of the tumor using a 100 time the exoscope. Let's see the surgery. So here you have the patient after surgery. He's doing very well without any symptoms or signs. She's very happy. I don't have here her video. It's a shame. Let's see something. Hold on. So it's an immersive surgery. You can see here that was the case of the patient. This is me in the left side, and making sure the resident of the right side remove the complete of the tumor. Those are my residents. We're operating an aneurysm. We're all looking to the monitor. It gives you an immersive way of surgery there. And you have a intraspinal ependymoma you have there. You can see the pre-op image. Okay. This is the C1, C2 schwannoma. We are going to see the surgery now. No, that's the ependymoma surgery. It was a big ependymoma going through C2 to 7 to C7. I fixed the spine first because the atrophy of the muscles could lead to a kyphosis. I used the exoscope 100% of the time here. Opening the dry matter, you can see the image of the exoscope. It is a good quality image. It's a 2K full HD vision, 2D vision. It has no deep field. It has no stereopsis. I'm doing the myelotomy there. So you can see the tumor there is very vascular. It has so much attachment to the spinal cord. You can see the tumor. Now I'm looking to the plane there, the cleavage plane. Always using neuromonitoring. You can see the pulsation now of the spinal cord. I'm at the upper pole of the tumor now. I had to do an internal decompression because of the bleeding. I didn't want to move a lot the spinal cord, you know. I'm taking out some of the adhesions. Now I can move the rest of the tumor down. I'm peeling down the tumor from the spinal cord, always using the exoscope. I had a lot of training first. I was confident. Now I'm on the lower pole of the tumor. Okay, you can see the cavity there. I remove all the tumor. This is an hemostatic agents. That's the closure. Some stitches.
That's it.
Okay, and that's the closure of the dura. So you can see here the patient. The patient was very symptomatic. You can see in the right side. You can move her legs, her hands. You can see the atrophy that she had. She's very happy now. You can see on the left side, the pre-op and the post-op. You have no tumor there. You have no syringomyelia there. It was a very beautiful case. Now you have a severe lesion of the right median nerve. You can see there, the patient had a neurinoma of the median nerve. A oncologist removed all the tumor, thinking it was a muscular tumor, or a myosarcoma. He thought it was a tendon. It was on a tendon. He removed it, but then the patient with the symptoms came for him, and then he sent me the patients. So you can see here in the left side, the upper part of the right median nerve and the lower part. It was a 10-centimeter resection that he performed. So I need to reconstruct the median nerve using both sural nerve. It was a three graft sural nerve technique. You can see in the right side, you can see the surgery. We are stitching one of the sural nerve to the median nerve. You can see the fascicles there. This was the team. We were two neurosurgeons, one looking at the sural nerve, and I was now dealing with the scar tissue 7 days after his first surgery. This is a complete sural nerve right in the right side. We trim it to get three pieces of sural graft to do the surgery. So you can see here in the left side, the surgery, the anastomosis of the nerve, the tree graft technique. I was both using the exoscope and the loops there. Maybe I used the exoscope. I'm not gonna lie, maybe 30 or 40% of the cases, because when you have peripheral nerve surgery, the ends of the nerve you're stitching, they move a lot, and you need to move the exoscope. It's not very good for that, but it's good to remove the scar tissue and to trim the nerve. Now you can see here pre-op and EMG, pre-op and post-op EMG 6 months after surgery. The patient is doing very well. So we have another spine case. This one is a tumor as well. I have no good images. Sorry for that. Here in my country, we have maybe a 1.5 or 0 to 3 Tesla MRI. So in the T2 weighted image, you can see a tumor. Let me show you. It's in the, let's see. Okay. It's in the conus medullaris there, the tumor. Hyper intense as well. Here you can see better the tumor. It's in the ventral part of the caudal echina, touching the medullary conus there. So let's see the surgery. It was a neuromonitoring there. All the residents, those are my residents. I didn't scrub for the surgery. I was looking at the screen, talking to them. I let them be surgeons. One of them is in the last year. He's a very good surgeon. And I was confident and I was teaching them. I was there with them, immersed on the surgery, looking at the screen. And maybe I don't have a video of this. That's a shame. But you can see the post-op imaging in the left side. The patient it was a complete resection. And you have now, you can see the patient, he's doing very well and he's happy. It's a shame I don't have video. I need to edit the video. It's a long video. So you have some advantages. You have low cost device. It cost me $1,000 for all of the stuff. I can move the exoscope to different hospital. Besides a microscope you need to put it on a hospital. You cannot move a microscope the same day to a different hospital. I can do that with the exoscope. I don't need to put a sterile bag over the exoscope to move it. I can sterilize it using gas in a maybe 12-hour sterilization. But the drawbacks of the exoscope are that you have no stereopsis. And I know that we neurosurgeons need a lot the stereosis, the deep perception of the field. And you need a learning curve. It took me maybe 10 cases to adapt to the loss of the deep of perception. So I hope you enjoyed the presentation. Thank you very much.
You know, Dr. Peralta, I think some people don't know you're doing that from a smartphone in your car, right? You're doing the presentation?
Yeah, sorry for that.
No, I'm just complimenting you to be able to, have such a good presentation from your car on a smartphone.
Thank you.
So, okay, Manuel, comments?
Yes. Peralta was the first one who introduced me with this kind of technology to improve in low-income countries because he's using it. So it's very nice to see. I already saw it, what Peralta is doing with the Exoscope, but the most important is to try to spread this kind of technology as an alternative to the low-income countries, because there is a lot of places where they cannot perform some surgeries by the lack of and the instrument. And you can see with the $200 you can get the good alternative to the microscope. Of course, you're not gonna make some fancy stuff, but you're gonna solve a lot of people's problem. And that's the most important. Try to do our best, because it's easy for people who say, I received somebody told me, like, if you want to be a top neurosurgeon, you need to use like expensive stuff. Yes, John, I hear that. I hear that. But people need to remember the world outside of the walls is different. And there is a lot of top neurosurgeons who don't have the top instrument, but they are making good stuff and saving life. And that's the most important. Do our best to save people's life, not to be a top neurosurgeon. Do our best and save people's life. Thank you, Peralta, for your presentation.
Thank you very much, my friend.
Okay, more comments, questions from the panelists? Hello, Omar. You're quiet. Abraham, how you doing?
Okay, I am here, Dr. John.
Okay,
How are you?
welcome from
Thank
Syria.
Thank
Welcome
you,
from Syria.
Manuel, Dr. Manuel. From Syria, yes. Thank you, Dr. Manuel. Good presentation and good lecture. Very nice exoscope.
Very
Thank
good.
you.
Okay, okay, Ibrahim,
Congratulations, Ismail. Congratulations for your work. It's very you operate a very complex surgery with that exoscope, and it's not easy to do it. It's not easy to do it, but we show the different operation with good results. So congratulations.
Thank you very much, Doc.
We need to develop more and more this tool with the minimum of cost. Thank you very much. Thank you.
very,
Ismail.
very good. Harshad, do you want to say something?
Hi, John. It's like
Hi,
excellent
welcome.
presentation. I can understand one thing, low cost exoscope are going to be available easily now more and more. And so we can use it first of all, we have to practice it and then use it. And I had inquired with many people, many top brass, that will it be replacing the microscope in future, the exoscope? And majority of them, they say that yes, it will replace the microscope. So exoscope use is a fantastic tool. And this low cost tool is wonderful. I would love to procure it once. I don't know where we get it. So wonderful.
Where he left
Where
some
can we get
information. Have
Yeah.
we left some information, right, Manuel, on the chat?
Yes, yes. I left the link. You can get it in AliExpress, for example. That one is the one I'm using and costs $115. So as you can see, maybe you can even have 2 exoscopes in each side of the operation table, and each one of them watching the different position. So with the very few money, we can do a great stuff.
Excellent,
Okay.
excellent.
Yeah,
Very good.
we'll stay in touch, Harshad. I'll give you the
Thank you,
information.
thank you, thank you.
Okay, any more comments, questions?
I'd like to add something, John.
Yes, go ahead.
that's
Hey,
good to
Abraham,
see you.
welcome, welcome.
Thank you, thank you.
Could you
Well,
please
Dr.
introduce
Peralta.
yourself? Could you please
Yes.
introduce yourself first, Abraham?
Yeah, for sure. Well, it's nice to meet you, Dr. Peralta. I'm Ibrahim. I'm a final year medical student or intern in Zurich, actually, but currently in Cologne. And Manuel and we've been working on multiple projects, including the Exoscope. Now I'm trying to support it. I'm trying to see how we can, make it more accessible and how to publish it in a nice way. And this, I think, of course, the major limitation, as you mentioned, was the lack of 3D vision and depth perception. But I mean, you mentioned how long it took you to overcome the learning curve. I think 10 cases is pretty nice. But you also mentioned that it was difficult to maneuver it, right? To readjust the position and everything. I mean, it seems like a very light device. And when I look at an operating microscope, it always takes 2 hands to maneuver it. So, I mean, I myself, as someone who does not have that device on his desk right now, I don't know exactly why it's difficult to readjust it, right?
Yeah.
And perhaps we can think about how to make it easier. Like, do we need to, add another piece, another, tool to make it easier to maneuver it with one hand? What is it that we need to do here?
So, first of all, as you mentioned, it's a light device. You can move it easily with one hand, but as it is light, it has vibration when you move it. So you need to wait until it stops the vibration after moving it. Maybe it took 3 to 4 seconds, but when you're doing this kind of surgery, you're desperate. You want to see the image right away, So, and the second thing is that it has maybe 5 joints parts that you need to manually move the knob and
Okay.
tighten to move it. You know, that's the thing.
Okay. Yeah, no, okay, I see. I see why it makes sense to use it in spine cases then more often
Yeah.
than in cranial.
Yes, excuse me for interrupt you. Something I'm using, as you can see, I am using a microphone arm to give you stabilization and also give me mobility. But you know, I am thinking maybe we can use a different arm, articulate and more precise. Maybe a Martin's arm. If you can use a Martin's arm, it's more accurate. And I think it's gonna solve a lot of problems for all.
Okay, there are a couple of people asking questions about the parts, etc. Can you post your email, Manuel, on the chat? 'Cause
Yes, of course.
People will be asking you questions. Okay.
Actually, if we're talking about parts, now the link that takes us to the AliExpress website, there it shows 115 euros or something to buy this, the camera along with its holder. But Dr. Peralta, I think in your presentation, you mentioned $750 at some point.
Yeah.
So does that include the shipping, or what else does that price include?
It included the shipping, the LCD screen, and I bought it on eBay 3 years ago.
Okay.
And all the parts, including the screen, the cables, the shipping, and that stuff, made roughly $7,000, $700,000.
I thought you said 700,000.
Yeah, 700.
Okay. Okay, more comments, questions?
Yes, hello, doctor.
Go ahead.
Yes, in this side, Dr. Edwin Bernard. I belong to the Russian team in the central hospital of the Russian Academy of Science with the Dr. Encarnacion. I want to congratulate Dr. Peralta. I didn't know that you guys had so many cases over there. It's very interesting, and the diversity of cases you also have. In our experience, our team, I want to share with you a little bit what I have seen as technical support working with Manuel and our team. And what I can say is that there's a good future for the implementation of this technology, chip technology. And I dare to go further and say that in the future, maybe we're going to be more familiarized with the use of this, because the main problem now that we have, as Dr. Peralta said and Manuel, is the depth. We don't perceive depth and needs a little time to feel comfortable working with it. But in right now, there are many companies, microscope developers, which are implementing 3D cameras that can be adjusted to 3D screens. The company, for example, says the same company, Olympus Orbi, has 3D cameras. And in the short future, I can say that these 4K cameras also will be implemented with the 3D technologies as well. Right now, we are talking about, in our case, we started with a very cheap equipment, but with a little more, I think 3D technology can be implemented and solve the situation of the depth, the perception. At the beginning, we had the problem with the installation because of, as the doctor said, the vibration of the instrument is very light. But after some experience, we can do it in 5-7 minutes in our case. the equipment has we can say the advantage of the installation time is minimal. At the same time, we use it in the connected to the operation table sometimes, but it can be also with the proper mechanical arm in the endoscopical tower as well. I think in the future, there's going to be a good opportunities for countries, developing countries, and countries who doesn't have even access to any technology to start. So our main goal is to give and make a presentation for those countries that we have availability for those technologies, and we can give them and start point to start using technology. As Manuel said, it's not an equipment we use, for example, in Europe, United States, here in Russia, actually. But well, for those countries, it's a miracle, I can say. So we don't want anyone to mislead the situation that we want to replace a microscope. That's not going to be possible, of course. But we want to say that this is the opportunity for those countries and those neurosurgeons and surgeons in general, because it has many applications. It's an opportunity for them to introduce it as a technology while they can access the high tech of the microscope. That's what I want to say. In my experience, I think it's 100% profitable for those countries, and the access is 100% guaranteed. That's what I wanted to say. I congratulate the expositors for the good presentation. Thank you, sir.
Thank you. Okay, before we close, Manuel, you want to say some words?
The only thing I just want to say, just to close, is maybe if some of the participants can get this kind of exoscope, we can make a multi-central trial and see the results of them and see what can happen. Because this is science, and in science we need to try and compare our results each other and see what we can do.
Very good. Okay, I'd like to encourage everyone to come to the Zoom lounge after we end this broadcast. Manuel, the link is in the chat. It's after this webcast. You have to end this Zoom and then start another Zoom. But it's private, it's not recorded, and we have it's a meeting place for students and the presenters. And Israel, I sent you the link, Dr. Peralta. You're there, Dr. Peralta, right?
Yeah.
Yeah, I sent you a link. Come into that lounge after this one is over.
Okay, John.
Okay, and I encourage all the panelists can come. It's private, non-recorded, and it's worked out pretty good. So thanks everyone for participating, including the Dr. Peralta. Wow, that was quite a webcast. So, okay, we'll see you in the lounge.